Good morning. Welcome everybody who's in the room and welcome everybody who's joining us virtually on Zoom. I'm Cara Carter. I'm the Senior Vice President for Programs at the California Healthcare Foundation, and I am thrilled to welcome you all to this briefing. I'm so pleased that we can gather here today to take a close look at some of the proven supports that California is supporting to help people experiencing homelessness be linked to housing. Many of you know us and many of you don't. So just quickly for folks who don't know us, the California Healthcare Foundation is an independent nonprofit philanthropy. We work to ensure that we work to improve the healthcare system so that all Californians have access to the care that they need. We focus particularly on making sure the system works for Californians with low incomes and for communities who have traditionally faced the greatest barriers to care. That certainly includes people experiencing homelessness. We're headquartered in Oakland, we have an office here in Sacramento, and we have a number of colleagues that live in Southern California. Our convening today is one of a series of regular briefings that I see many familiar faces and know many of you attend regularly. We do these in person and we have colleagues that join us virtually. We sponsor these for the Sacramento policy community. And these briefings typically have two purposes. So first, they're here to bring you the information relevant to key healthcare issues and trends. And secondly, we're here to promote dialogue on possible solutions to some of the biggest challenges facing our state. In addition to those of you here in the room, we have more than 900 people registered via Zoom. It is the biggest Zoom attendance we've had for one of these briefings, certainly since I've been at the foundation, which is about 8.5 years. So we'll make a video of today's briefing available, so anybody who wasn't here or wasn't able to make it today can watch it later. We've published a pretty large array of resources about healthcare and homelessness, so you can find those on the registration page for this event. We'll include that link for everybody who registered. I can only imagine that everybody here today shares my deep concern about the homelessness crisis in our state. As I mentioned, CHCF's offices are in Oakland. I also live in Oakland. I am an Oaklander. Nearly 5,500 of my fellow Oaklanders experienced homelessness last year. They're part of the 186,000 people statewide who didn't have a home for all or part of 2024. And I also believe, since we're here in the Department of Healthcare Services auditorium, thank you to our friends at DHCS, that you all recognize the role that healthcare has in play in helping people experience homelessness achieve better health and get connected to permanent, affordable housing. Of course, there is no single department or agency that can address this crisis independently. That's why partnership is crucial, so that we can fully assist people who need our help the most. This kind of cross-sector collaboration, particularly between healthcare and housing, is critical to finding solutions to make our way out of this crisis. Under CalAIM, the state recognizes that organizations with the greatest expertise in building trust and assisting people experiencing homelessness are the on-the-ground partners that have worked in these spaces for years. Through CalAIM, these key partners can be reimbursed for much of the work they do, including 3 housing community supports. Today, you'll hear more about how these supports can be used together to help people move into stable housing. Before we get into the heart of the briefing, we wanted to set the stage by hearing directly from someone experiencing homelessness. Marilyn Forte was interviewed for a statewide documentary project that CHCF was proud to support called Unhoused. People who consented were photographed, and interviews were recorded. They're audio only. So let's take a moment and listen to Marilyn. This excerpt runs for about 2 minutes.
Hi, my name is Marilyn Forte. I'm 61. I have chronic kidney disease, and my kidneys are failing, but I have a stent in my arm. I have to start dialysis sooner than later because the doctor up here, he doesn't want to start it until I have a place to touch down. I start dialysis. They will take care of me here, but I need a place of my own where I can rest. You can't exactly rest here. Dialysis will take your strength 3 times a week, so it is pretty draining. But I need to take care of me, so whatever comes first, I'll take it. 2 years ago, I got sick, woke up in the hospital, didn't know how I got there. I had a colostomy bag, legs swollen really bad. I was in bad shape, I didn't know it. At the time, I was in the hospital for 3.5 months, and my landlord said I'd been gone so long he thought I had left or died, and then I came back. And my sister took care of me for 10 months because I had wound changes. I want to get into a place, start dialysis, and cook my December dinner. That's what I want to do. They want to price you out of apartments, but they have senior apartments I'm looking at. And I have one on the hook, but I still got to call, because I'm on the list. And I'm hoping to get in soon because I need to start dialysis. Very hopeful.
If you all found that hard listening, I can assure you I share that sentiment and feeling. As someone who 10 years ago was faced with a cancer diagnosis and had to face the fear and scares and horror that come with facing serious illness and treatment, it's very difficult for me to imagine what it would have felt like if I was also facing homelessness and an inability to rest and delays to treatment caused by a lack of access to stable and affordable housing. Unhoused is a companion piece to the landmark California statewide study of people experiencing homelessness. The lead researcher for the study is Dr. Margaret Kuschel. She is the director of the UCSF Benioff Homelessness and Housing Initiative. Today, she'll join us to share some of what she's learned. Please join me in welcoming Margot Kuschel.
Thank you so much for being here in person or on Zoom. Today I'm going to talk about homelessness and health and the urgent need for cross-sector solutions. I come to this as both a researcher, but also as a practicing physician. At the heart of the homelessness crisis, without a doubt, is the lack of deeply affordable housing. In our home state of California, there are only 24 units of housing available and affordable for every 100 extremely low-income renter households. That means we are 1 million units short of where we need to be. But in the setting of this massive crisis of affordable housing, it's important to sort of separate the drivers, or the things that drive the difference between states or communities with high rates of homelessness and low rates of homelessness. These are the systemic factors that create overall homelessness rates and explain the differences in rates between the communities, which really can be explained by the lack of affordable housing and income inequality, as put forth in their wonderful book, Homelessness is a Housing Problem, by Clayton Aldern and Greg Colburn. But they distinguish between these drivers, which sort of say, we have a big lack of affordable housing in California, a big disconnect, therefore we have a lot of people who are homeless, and what they call the precipitants, or the individual risk factors that determine or increase the chance that any given person within their community experiences homelessness. Chief among these are substance use disorders and mental health problems, which help determine within a community who is more likely to experience homelessness. I'd like to complicate their vision even further. Not only do people who have behavioral health problems or other forms of disability, often drawn from trauma, have an increased likelihood of experiencing homelessness, but homelessness itself worsens these problems. Being homeless exposes you to trauma. Being homelessness exposes you to despair, lack of sleep, terrible environmental conditions, interrupt your ability to seek treatment, just like you heard from Marilyn just before. Therefore, there is a complex interaction between these health problems, which put you at higher risk of homelessness, and homelessness, which then worsens these problems, creating this loop. So it is true that people experiencing homelessness are much more likely to experience these problems. As one of our CASPA participants put it, describing their experiences, most of the time we're running around, trying to figure out where we're going to sleep at night. We're not worried about going to the doctors or going to see somebody. or going to get help with our mental state. In CASPA, which is a cross-sectional study, meaning like any cross-sectional study, it talks about who is experiencing homelessness right now, as opposed to all the people who might experience it over the course of the year, and therefore is going to overrepresent the folks with the more difficult problems who are likely to stay homeless longer. But within that, you can see the really shocking racial disparities. For instance, at any point in time, 26% of adults in California experiencing homelessness reported a Black racial identity compared to 7% statewide in the population. 12% reported a Native American, Alaska Native, or Indigenous identity versus 3%, and 35% reported a Latina identity. At any point in time, homeless adults are more likely to be men. 69% were cisgender men and 30% were cisgender women. 1% reported a trans or non-binary identity. This is an aging population. The median age of adults experiencing homelessness in California was 47. Everyone in our study had to be 18, but the oldest person we spoke to was 89. Among the large group of people experiencing homelessness who are called single homeless adults, meaning they're not the young homeless youth and they're not parents living with children, 48% were 50 and older. Of those 50 and older, 41% had never been homeless, not even for a night, before the age of 50. In California, if you experience homelessness, you're very likely to do so in an unsheltered setting. 78% were unsheltered, 21% living in their vehicle, 57% in a non-vehicle setting, like you see here, a photo we took during our study. Only 22% spent most of their time sheltered. Homelessness is harrowing. 36% reported that during this episode of homelessness, they had experienced a physical assault. 10% had experienced a sexual assault during this episode. This was more common among cisgender women and members of the trans community. And importantly, while people were homeless, about half of those episodes of violence were perpetrated by a total stranger, someone they didn't even recognize as an acquaintance, which is very different than how we see violence play out in the general community. It is not surprising, both because of the increased risk of homelessness and the way that homelessness really destroys your health, that 45% reported their health as poor or fair. This is a very important indicator of future need for hospitalization or mortality. Even though people had poor access to care, 60% reported one or more major chronic health condition like failing kidneys or diabetes or cancer. And over a third of all adults reported at least one limitation of one of the 5 major activities of daily living. In those experiencing homelessness, over a quarter, or 27%, had experienced a psychiatric hospitalization at some point in their lives, but 44% of whom had experienced it only after they first became homeless. While people were experiencing homelessness, there was a lot of mental health symptomatology. 2/3 reported a significant mental health symptom, but this was driven primarily by serious anxiety symptoms and serious depression symptoms. However, 37% noted that they were having trouble remembering, concentrating, or understanding, and 12% reported currently experiencing hallucinations. Of those who reported a serious symptom, fewer than a quarter, or 24%, had received any form of treatment in the prior 30 days. And 5% had had a psychiatric hospitalization in the prior 6 months. Substance use was common. 37% reported using illicit drugs 3 or more times a week during this episode, and this drug use was mainly driven by methamphetamines, of whom 33% used. 10% reported chronic or 3 times a week or more use of non-prescribed opioids. Most of those people also reported methamphetamine use. But importantly, 23% of the entire population reported that they had only started using drugs regularly after they became homeless. I started, I guess you could say, using when I became homeless, meth, I would use it to stay awake at night. So it's not like I would need a fix in the daytime or nothing else. 9% reported currently weekly heavy episodic alcohol use, and if you combine those, 40% reported either regular illicit drug use or heavy alcohol use. Of those who reported these problems, only 10% were receiving any form of treatment or counseling, and most of those were receiving less evidence-based forms. 26%, though, of those who likely would benefit from treatment reported that at some point during this episode they had sought treatment but been unable to get it, despite trying to. Across the whole population, and remember, this is cross-sectional data, so it's going to find more people with chronic homelessness and more of these problems, but 48% reported either current regular illicit drug use, heavy episodic alcohol use, current hallucinations, or recent psychiatric hospitalization. Our state has done a good job in expanding Medicaid and increasing access. In fact, 83% knew that they were covered by some form of health insurance, and it was almost all through Medicaid. 52% reported having a regular source of non-emergency department health care, a clinic or a doctor's office. 12% of this group received it only through a mobile clinic or street medicine team. Despite this, 39% had not visited a healthcare provider outside of the emergency department in the prior year. 24% reported an unmet healthcare need, and 23% an unmet need for medication. When you put these together, you find extremely high use of acute care. 39% of all adults had visited the emergency department in just the prior 6 months, and 22% had had an inpatient overnight hospitalization for physical health in that time period. So what do we do? Clearly, the primary response to homelessness is to increase the availability and affordability of housing for the lowest income households. We have to do that, and we won't solve this problem without it. But there is clearly a critical role for healthcare in this response, particularly, I would argue, in the need for an alignment between the healthcare, homelessness, and housing systems at all stages of the homelessness response, from prevention to post-homelessness. I'd like to provide you with a way that I think of this schematic. I think of the opportunities to prevent people from becoming homeless or homelessness prevention, intervening at the point before people lose their housing. I think of the need to mitigate the negative impacts of homelessness on people's health and well-being while they're experiencing homelessness. I think of the need to speed exits, to improve people's access to resources that would get them out of homelessness. And then we think of those exits, which I would put as either a small group of people who need what I would call a higher level of care, like residential care facilities, assisted living, nursing homes. That group should be as small as we can make it. A larger, much larger group of people will need something we call permanent supportive housing, which is subsidized housing with aligned voluntary services, which is shown to be extremely effective at ending homelessness. And even within PSH, there is a wide range of service modalities that you need to meet the needs of the individual. And finally, a large group of people like Marilyn, who you heard from, who had been housed her entire life until a health crisis in her 60s. What they really need is rapid access to housing that they can afford, and then we just wrap around mainstream services to them like I do for most of my housed patients. So let's talk about the role of this cross-sector collaboration in homelessness prevention. I would like to argue that we can make better use of healthcare interactions. That is a system that people touch with and a system that people trust, to identify those at highest risk of losing their housing and to get the interventions to them. The VA system, in partnership with HUD, does a wonderful job with this. We now know that there are models that can predict who is likeliest to become homeless, but it's very hard to actually find them. We could find those folks and do the interventions using healthcare sites. And we could use healthcare dollars, flex pool funding for brief interventions to prevent homelessness through things like housing, CalAIM Housing Transition Navigation System services, and others. Another key point of intervention is the high number of people who become homeless after leaving institutional care, whether that's our carceral systems, our jails, or substance use treatment programs. This is a place where we know people are leaving to homelessness, and we could use healthcare dollars for interventions such as CalAIM's new short-term post-hospitalization housing and community transition services. How about once people are homeless? We can say all we want that the solution is to end their homelessness, but we need to keep people alive and safe during their homelessness. There are many ways that Medi-Cal can cover crucial services. I'm highlighting two here: street medicine, the provision of healthcare directly to people who are unsheltered, using walking teams, medical vans, outdoor clinics, and the Medi-Cal benefit of enhanced care management, where care managers meet clients wherever they are physically and also sort of in their life's journey. Other things that Medi-Cal can help with are providing alternative sites, meaning non-institutional sites, non-hospitalization sites, to reduce the reliance on acute care facilities, which, as you can see, is very high. Things like recuperative care, also known as medical respite, short-term medically supported residential care for people experiencing homelessness leaving hospitals that can shorten lengths of hospitalizations and ease transitions to the next step, as well as reduce readmissions. Sobering centers, short-term supportive environments for those experiencing public intoxications where they can be cared for safely to avoid having people either in our emergency departments or our jails. These programs can also engage people in treatment. How about improving homelessness exits? Housing navigation and flexible fundings are absolutely critical to reduce barriers to exits. In our study, we found a shockingly low number of people who had received these forms of housing navigation, searching for housing, engaging landlords, paying first and last month's rent, making it easier to exit homelessness. Healthcare systems can identify those who need assistance, direct them to help, and also, I would argue, risk stratify them so that we get them the right level of help for the right person. When I think about housing, I realize that many people will eventually self-resolve their homelessness. In fact, most people who leave homelessness do so without any help from outside sources. We could make a measurable difference, both in people's lives and in the number of people on our streets at any given day, if we can shorten those self-resolution episodes. If it would take someone a year to come up with strategies to put together the funding to move in with friends or family or to get a shared apartment, what if we used a small amount of resources to shrink that year to 1 month? You would see dramatic decreases in the number of people experiencing homelessness and dramatic decreases of the harms of homelessness. Strategies like flexible funds and housing navigation, now that can be used through Medi-Cal and other benefits, could make a big difference here. Some people need more than that. Some people need a short-term housing subsidy. You think of people who have the opportunity to re-enter the workforce may need a time-limited subsidy to get them back in stability. And many people in our brutal housing market are going to need a permanent rental subsidy. Some people need a little more. Some people need subsidized housing with routine supports, permanent supportive housing with routine support services for those with behavioral health or physical health difficulties who need more services than we can get in housing with mainstream services alone. And still others will need subsidized housing with what I would call intense supports, permanent supportive housing with intensive care management or assertive community treatment models, or permanent supportive housing tailored towards medically fragile or older adults. We know from repeated studies that even amongst those with the most significant behavioral health disabilities, you can successfully house upwards of 85% over the long term, so long as you provide the right level of support, which can be quite intensive. Once you do that, there will be a small group of people who will require alternative and more costly models of care, like residential care facilities and dementia care facilities. We need to do a better job of filtering people so that they get the right amount of supports, so you're not placing people in these higher levels of care who could thrive in a lower level of care, but that these facilities are available for those who need them. The healthcare system can work alongside homelessness and housing systems to identify who needs what level of support. The healthcare system does this on the daily. This is what we're really good at, and we need to partner with the housing and homelessness services to help identify who needs what level of supports. The healthcare system also needs to be a player in providing these supports. Funding reforms such as CalAIM, the Behavioral Health Services Act, BH Connect, can lower barriers to pay for these appropriate services and supports. There is no question that many barriers remain. Healthcare cannot solve this problem on their own. CalAIM housing supports are one tool in a large toolkit. Managed care organizations need more expertise and assistance to be able to operationalize their enormous potential to help play this role. And we clearly need to lower barriers for homelessness and housing sectors to collaborate with the healthcare system through making it easier to exchange information, to speak the same language, to be in the same rooms. As I like to say, different individuals require different solutions. And within any given individual, people require different solutions at different parts of their own journey. Homelessness is preventable if we reach the right people at the right time with the right interventions. When people are experiencing homelessness, we need a response that matches their own needs. Everyone needs housing that they can afford. That is at the base of this crisis. Some will self-resolve their homelessness. We could speed that. Some need navigation and flexible funds to help them access housing. Some need that plus short-term support, subsidies. Others require that plus light touch services and supports. Others require housing with long-term subsidies plus significant services and supports. And some, a smaller group, are going to require structured, supportive living environments. The healthcare system has an important role to play, but can only operate in close partnership with homelessness and housing systems. And we need to continue to believe, as I very much do, that homelessness is solvable. Thank you so much for your attention. Here are some ways to contact me, and I'm thrilled to turn the mic over to my colleague and friend, Dr. Michelle Schneiderman, who is the director of People-Centered Care at the California Housing Foundation, a physician who has devoted her life to this work. Thank you.
All right, this mic is working. Thank you, Dr. Kushel, for that incredible presentation. The groundbreaking research you and your team conducted is really helping shape the way we all think about homelessness and its solutions. I'll push that further away. You inspired us to think about the ways in which we can collectively work toward a future where homelessness is rare and brief. I particularly appreciated how you walked us through the need for better alignment and the ways to get to better alignment and coordination between healthcare, homelessness, and housing systems. CalAIM provides a rare and critical opportunity for that kind of cross-sector alignment. And if we do it right, an opportunity to improve outcomes for people at risk for or experiencing homelessness, particularly those who have complex needs. I am so delighted to be joined by a panel of experts who can help further the conversation about cross-sector collaboration in CalAIM. Our goals for the panel are to help us all learn more about CalAIM's housing supports, but also to help us learn how our systems and how our collaborations need to adapt to be able to deliver these services to Californians who need them. Before I dive into conversation with our panelists, let me quickly introduce them. To my left, your right, immediately, is Susan Phillip. Susan is the Deputy Director of Healthcare Delivery Systems at the California Department of Healthcare Services, or DHCS. Next to her, I'm joined by Dakshika Wikrema, the Deputy Secretary of Homelessness at the California Business, Consumer Services, and Housing Agency. I will likely refer to that as the Housing Agency. And Cheryl Winter, the Associate Director of California State Policy at the Corporation for Supportive Housing. Dr. Kushel is joining us as well to offer some final reflections after our conversations. Susan, will you start us off with an overview of your department's approach to housing for health and CalAIM's housing supports?
Great, thanks so much, Michelle, and thank you so much for the opening comments. Dr. Kushel, it was really very nice way to set the platform for really how healthcare and housing really do interplay, and all the initiatives that we collectively have to really undertake over the long term to address our housing and homelessness problem in this state. So first of all, thank you all so much for having me here today and for being part of this panel. It really is a pleasure. I'm, as Michelle said, with DHCS. We're headquartered right across the street, and we are the state Medicaid agency overseeing our Medi-Cal program, which, as many of you might know, there are 15 million Californians enrolled in Medi-Cal, most of which get their health care through the Medi-Cal Managed Care Program. So over the last several years, DHCS really has undertaken a transformation initiative for Medi-Cal. We have been building on prior waiver initiatives, which is really our contract with the federal government on how we administer certain aspects of the Medi-Cal program. And we have been really looking at the whole person, right? You know, not just addressing healthcare needs, but what are the social drivers? And how do we actually address the upstream effects? So CalAIM is a key initiative. We know, of course, that housing stability is a crucial aspect of health and well-being, and it directly impacts our physical and mental and behavioral health. So under CalAIM, we really doubled down on our efforts over the last few years in addressing the needs of the whole person. Under CalAIM, there's a number of initiatives. I'm really going to be focused on community supports. Some of the initiatives related to enhanced care management that was touched upon is also a key pillar program where ECM really does help support individuals, populations, a focus, as we call them, for individuals experiencing homelessness and helping to coordinate and navigate both healthcare, clinical needs, as well as social needs. Community supports is really an area that I will be focusing on. The community support services are optional services that are offered through our managed care program. So what that means is under managed care, plans are not required to offer them, but they're highly encouraged to offer them. There's a menu of 14 different community supports, and these services are really designed to address social drivers of health. 3 of which we call the housing trio, which was touched upon. So that includes housing transition and navigation services, housing deposits, and housing tenancy and sustaining services. Just to expand on those 3 a little bit more, housing navigation is really intended to help individuals navigate and secure housing. So this bundle of services that could be covered under housing transition and navigation services includes helping an individual really conduct their housing needs assessment, developing an individual housing support plan, searching for housing and assisting in securing the housing, and then really doing some of that initial landlord education and engagement. Then there's housing deposits, and that's exactly what it might sound like. It really is intended to help individuals with that one-time setup costs for their household, right? So helping them establish a basic household, fees and costs associated with initial furnishing, and that initial security deposit to secure that housing. And then housing tenancy and sustaining services is really intended to help members maintain the housing once they have secured that. And that is really important for this population. When we think about individuals who might have been chronically homeless and unhoused for many, many years, that housing sustaining and tenancy support services is really critical to helping them maintain that housing. So that bundle of services really includes things like assisting the individual with resolving landlord issues or maybe neighbor disputes, helping them learn how to advocate for themselves, and also working through that housing support plan and making sure that that is updated. So for example, if an individual is in interim housing, what is a game plan in helping them secure permanent supportive housing? So really quickly, how do members who are experiencing homelessness really access these services? So as I mentioned, Medi-Cal is available to our Medi-Cal members, and then it's through the Medi-Cal managed care plans. So our Medi-Cal managed care plans have contracts with community support, community-based providers that are providing these different community supports. So over the years, DHCS really has invested heavily in the infrastructure and capacity building of our delivery system. So we have, through the Housing and Homelessness Incentive Payment Program, for example, those were dollars available to our, through our managed care plans to really build out relationships with housing partners, for example, and then also develop and build out partnerships with community organizations that could become community support providers. We also had a program called PATH, which stands for Providing Access and Transforming Health, and that is really dollars and opportunities for on-the-ground partners, such as CBOs, hospitals, county agencies, tribes, and others that are really interested in becoming community support providers or ECM providers as well, and really building that capacity. And as I mentioned, these are the housing trio. There are two other community supports that was alluded to. One is recuperative care, and then short-term post-hospitalization housing. These two community supports have a room and board component, and they're really intended to address the needs of individuals who may be experiencing homelessness but have recently transitioned out, for example, out of a hospital. It's really important that they have a safe place to recover and heal from an injury or illness, say, after a stay in the hospital. So that's the purpose of these community supports. I will mention that the two short-term the two community supports that I just mentioned, short-term post-hospitalization housing and recuperative care, are both authorized under our 1115 CalAIM demonstration waiver. The housing trio and the community supports at large are authorized through our CalAIM 1915B waiver, which leverages what is called our in lieu of services authority under managed care. Getting into a little bit of technicality, but it's important just for folks to understand the authorities by which we provide these services. And then under BH Connect, under 1115, CMS very recently approved transitional rent services. And this is a new community support, and it is really intended to support members that are really going through some of the vulnerable transition periods, and provide 6 months of transitional rent services, allow them to be housed, and the purpose is really to reduce that risk of returning to institutionalization or prevent them from becoming homeless. So that's a new community support. It is optional for plans to offer it beginning July 1, 2025, and then it will become a mandatory benefit come January 1, 2026. And this was just, again, recently approved by CMS in December. So that's a quick overview.
Thank you, Susan. That's really an amazing menu of services that are now covered by Medi-Cal. And as an aside, if anybody wants to go deeper into waivers, CHCF just published an incredible explainer about waivers that's really accessible and easy to digest, so I encourage you all to check that out. I wasn't going to start with this question, but since it is probably on everyone's mind, I'm going to get it out of the way. And that is, Susan, what can you tell us about how the department is sort of going forward in the face of federal uncertainties?
Thanks for raising that question at the beginning, Michelle. So, of course, that is a question, I'm sure that it's on top of everyone's mind. I will say, as a state, as a department, we are fully committed to really supporting community supports and the scaling of it. We have invested so much into developing the capacity in this space. When I mentioned housing and homelessness incentive payment programs, there's also the IPP, which is another incentive payment program. I mentioned PATH. These are all, each of these programs have been over $1 billion of investment in developing capacity throughout this state. And there has been a tremendous amount of capacity throughout this state. There's been organizations, CBOs, counties, entities, hospitals, for example, all have developed capacity, and we are fully committed to ensuring that there is that buildup in this space. You know, we're not going to speculate, you know, what the federal government might do, but as a state, just to reiterate and mention again that we are fully committed. As our director, Michelle Bass, likes to say, we are pedal to the metal on this. And, you know, with BH Connect having been approved just in December, you know, we're completely in building mode for the transitional rent community support, for example, and ensuring that we are building the policy, developing, and continuing the investment in the space.
Thank you. So we're a few years in to CalAIM. Susan, this is another question for you. What can you tell us about the successes in scaling this work so far? And what have you been doing to accelerate progress in areas that have been trickier?
Great, yeah, so with community supports, one of the things that we just said at the launch of CalAIM and acknowledged at the launch of CalAIM is that this is new, it's different. These are really, it is quite an undertaking for us to be essentially bringing in providers and CBOs and organizations into the delivery system that haven't necessarily been engaged in the traditional healthcare system, right? When you think about housing navigation, those are CBOs that, work with the housing and the homelessness, people experiencing homelessness, these specific populations, but they're not working with managed care plans per se, right? They don't have a contract with a managed care plan and doing, claims invoicing, right? These are not capacities and capabilities that these organizations and CBOs necessarily have. So we have seen that those are part of the scaling issues that we are addressing. However, the good news is we have really seen quite a lot of uptake of community supports over the years. Since just overall community support, since it's launched, over 240,000 members have used one or more community supports. And then in terms of uptake, so as I mentioned, community supports is optional. For the housing trio, the three that I mentioned, every single plan in every single county is offering the housing trio. So that's pretty much maximum uptake of those community support services, which is really great news. In terms of utilization for the housing trio, of all the community support services, In terms of utilization, the housing trio really has quite a lot of the utilization. Next up is recuperative care, and then medically tailored meals. Those are the community supports that really has the highest amount of utilization. And then, we have in the most recently available quarter of 2024, the second quarter of 2024, the data that we have over 30,000 members in that quarter have used housing navigation services. So there's been quite a lot of uptake, but of course, a lot of opportunity for growth. We do understand that there are individuals, of course, that really could use the services. Interestingly, we do know that there are services that are being offered, by CBOs, but they might not be engaged yet in Medi-Cal. So we're really looking to streamline those processes, make it easier for CBOs to engage. One of the promising, I would say, developments over the last few years is the development of hubs that have started throughout the state. So these are organizations that are basically providing that administrative capacity and services for CBOs so that they can then engage with the managed care plan. And that way the CBO doesn't necessarily have to do the actual claims invoicing, for example, and that the hub can do that for them. That way the CBO can focus on the bread and butter and actually serving the Medi-Cal members, and the administrative hub can really work with the managed care plans. Those are some promising practices and entities that we have seen growing throughout the state, and we think that these are areas that will definitely help scale community supports, and especially for the housing trio, when again, we're building in the capacity for CBOs that are newly engaged in Medi-Cal.
Thank you. Really appreciate hearing about attempts to create more efficiencies and reduce the administrative burden on providers. Dr. Shika, I'm going to turn to you. As we heard from Dr. Kushel, and as you know yourself, no one sector can improve homelessness outcomes on its own. We need coordination on the ground and within state government. Tell us about the Interagency Council on Homelessness and the role it plays in strategizing around and coordinating state programs.
Thank you, Michelle, first of all, for inviting me, and thank you, Margot and Susan, for really providing all that information. And I also want to shout out Julie Lois here, who's the first executive officer of the Interagency Council on Homelessness. And so, again, this is building on a lot of the work she did. We now have another executive officer, Megan Marshall, who comes to that role with deep expertise in counties. She was actually the public health officer during COVID in Placer County. So back to your question, Michelle, one of the things the Interagency Council on Homelessness does is, on top of the staff, and I'll get a little bit around the data system that is important here, it also staffs a state council. And on the state council is, for example, Michelle Bass, and there are 5 cabinet secretaries and 13 department heads and 2 CBO leaders, one from Northern California and one from Southern California. In fact, Professor Kushel is the CBO leader from Northern California. But one of the things they're trying to do is really make sure there's consensus at the state level across these multiple sectors. So we have not only Michelle Bass from DHCS, we also have the 2 co-chairs, my secretary, Tamika Moss, who leads housing and homelessness, but also Kim Johnson, who leads the California Health and Human Services Agency. We have Department of the California Office of Emergency Services, DOR, Office of Rehab. So you have this wide variety of sectors really represented at this body that meets once a quarter. But one of the things it does, it has an action plan to prevent and end homelessness. So that's one of the things I just want to talk about quickly. The first plan started during COVID, and it was an annual plan that was updated. But then last December, they did a 3-year plan, thinking about some of the data that you saw from Margot Kushel's study, you can see this is not something that is going to get resolved in a year. You really need a 3-year plan. Even that is not enough, but enough time for the state agencies and departments to really think about the activities and programs they have and think about how they can coalesce around a few North Star goals. So some of the goals include looking at data that is already being collected across the state. So within the state and within the country, there are these entities called continuum of care entities. These continuum of care entities are defined by HUD, the Housing and Urban Development Authority. They receive dollars from the federal government for housing and homelessness, but they also provide kind of an organizing, kind of networking facility at the regional level. There are 44 COCs throughout California. Each of these COCs are mandated by the federal government to collect data on how many people are being served, how many people are being exited to permanent housing, how many people are returning after being exited from permanent housing. And unusually in California, thanks to the pioneering work of Julie Lowe and now Megan Marshall's team, what California does is collects that data and aggregates it at the state level. And I'm going into detail about this because it connects to some of the work here and the data that Margot mentioned around inflow, outflow. The plan was approved in December, and if anyone has time, at 1 o'clock, the final approved plan will be discussed and implementation will be discussed. It's a public meeting from 1 to 4. But one of the North Star goals is how many people are served longitudinally over the course of the year. Margot mentioned the point in time numbers, but this plan collects the data and provides the longitudinal number. Roughly about 300,000 people every year are served by the system. Now, you might think that's a number we want to go down, and because DHCS, as I'm saying this, we want that number to go up because we want to serve more people. We want to drill deeper into community. That's a number we want to go up. The numbers we want to go down, for example, is how many people, once they're housed, return to homelessness. And then, so for example, how many people are exiting after being served to housing? The data shows, and you'll see this in the plan, that last year, 63,000 people across California exited homelessness to permanent housing. What that means is 1 out of every 5 people that are being served are exited to housing. So over the next 3 years, with collective action, so DHCS programs, CDSS programs, other programs that are providing services and housing to people who are unhoused, we want that number to become 3 out of 5. So that's an ambitious goal, but that's the kind of way we want to make sure every state agency and every state department, as they're thinking about their programs and their activities, and the activities are listed in the plan, they're really thinking about how do we help people exit unhoused situations to permanent housing situations. And that can be, as Susan mentioned, could be family and friends as long as it's stable. Could be a rapid rehousing voucher that is up to 2 years of rental assistance, and at the 3rd year, the people take on the rent themselves. It could be supportive housing. It could be board and care facilities. But it's a place where there's a sense of stability, a sense of dignity, where people can really take care of their health, be reunited with family and friends if that's something they want to do, but really use the resources with CalAIM and other resources to turn that chapter in their lives. So that's one way, Michelle, really using that action plan and using the goals and using that body of the 5 cabinet secretaries and 13 department heads and the community leaders to really think about how the state can work together. I will say, importantly, we also have a lived experience advisory board. So every meeting, we really think about the insights and how we can get guidance from the lived experience advisory board, some of whom are actively experiencing homelessness, to really see how we can infuse that wisdom and expertise in what the state is doing through the action plan. And then there's an advisory committee, which also has people representing different populations, the youth, the older adults, people who are survivors of domestic violence. So because we really want to make sure we are taking a really ground-up approach to this. I mentioned the data very quickly. So what HDIS does, the Homeless Data Integration System, it has a way now to have California-wide system performance measures. So I mentioned a few of them. How many people are being served over the course of the year? How many people are exiting from homeless situations to housing? But we also have, once people are housed, they track how many people are returning within 6 months. The good news is, based on the data that's been reported up from the community, once people are housed in permanent housing, 89% are staying housed. So you can see housing is really health. Housing is such a social determinant of health, because once people are receiving that housing, it's like treatment. 89% are staying housed. We want to increase that number of people retaining housing in the next 3 years. We want to push it, if possible, to 96% staying housed. And then we also track things around how many housing units are being built, because all of this work, whether you have housing navigation or housing tenancy sustaining services, is contingent on having places to place people. So just a shout out to folks in the healthcare world, if you see a housing, affordable housing, go to that meeting, say yes to housing. We need more housing, and I depend on all of you to do some of that advocacy in your communities. It's not just the folks who are the nonprofit developers, it should be all of us, because if you don't have units to place people, all the housing navigation is for naught. The last thing I'll mention around data is CalAIM, as we call the Interagency Council for short, has now entered into an agreement with the California Health and Human Services Agency to send the HDIS data once a quarter to CalHHS to do data matching with DHCS data and CDSS data, so that we can really try to understand who's being served, who's not being served in the healthcare and human services system. And that, at the end of the year, hopefully will provide us a prevention metric. Because we mentioned prevention, we really want to make sure we understand what healthcare systems and the human services system is doing as part of the safety net, and we can really try to prevent people becoming homeless in the first place as we start to exit people, so that we are taking a both-and kind of intervention here.
Thank you so much. I'm so excited about the data work that's happening at the state. When I was seeing patients at San Francisco General with Dr. Kushel, we used to say, we wish we could write a prescription for housing, that would be the most important prescription that we could write as a physician, and I hope that we're looking toward a future where that's possible. Dr. Shika, one more question for you. You just described a lot about what CalICH and the Housing Agency are doing and tracking. I am curious, though, what you're hearing from the homeless response sector and housing developers about CalAIM specifically.
It's tough. So I think, Susan mentioned some of it. When you're a housing developer, and I see Doug Shoemaker here in the audience, he can probably provide more details about this. Some of the challenge when you try to create affordable housing, even, leave CalAIM aside. When I talk to folks about the difficulties if you're a nonprofit developer to build housing, I always tell folks, imagine if your house had 7 mortgages. Because no one entity is able to fully fund everything. What that means is, if you're a housing developer, hopefully maybe the city or the county has land, and so let's pretend there's land. But then if you have to think about all the infrastructure and building and materials and labor, and I'm not even gonna mention like the community aspect of this, getting through that hurdle around the support from the community, because since before the 1980s, the federal government would fully fund the construction of public housing, affordable housing. All that went away in the 80s. And Now it's a public-private partnership. So what that means is that nonprofit developers usually are taking 2 lines of credits from banks. They're going after city RFPs, county RFPs, state RFPs, cobbling together all of these different funds on different timelines. So that's already difficult. Now, where CalAIM could be helpful, right, is on services. And part of the challenge is when you're underwriting a property development, like, you live in your house, you want the electricity to be paid and the water bill to be paid. And if the people in the house you're not sure if they're going to be in the house all the time. So CalAIM, because the money follows the people, you're not sure if the same people that come in year 1 are going to be the ones receiving CalAIM dollars in year 2 and year 3. So that kind of sequencing and kind of inability to really predict how many people, say in a development, have CalAIM resources and will remain on CalAIM resources makes it a little difficult for developers to really ensure that those CalAIM funds can be used in that way. However, Susan mentioned HIP. HIP has actually been used in multiple kind of housing projects in Alameda County, in Santa Cruz, in LA, where you can use it on the front end to really help jumpstart the rest of the development. So you've seen that happening in many places. There is some activity where people who are medical providers have been taking on the challenge of being developers as well. So there is a example in Kern County. Because they have a lot of folks on CalAIM, they are able to kind of balance their portfolio. So even if 10% fall out, they feel they have enough in the rest of their portfolio to make the numbers work. So there's a little bit of that going on. So that's in the housing, like strictly housing development world. I will say that in HAP, which is for people who don't know, there's a general fund, state general fund program called HAP that goes out to all 58 counties, the 14 big cities, that's cities with population above 300,000, and the 44 COCs. It's a flexible fund which can be used over 4 years, goes out by formula. And because in the HAP NOFA, we had put in requirements to really leverage health sector funds and human sector funds, human services sector funds, you're seeing in the HAP Round 5 application, lots of leveraging of CalAIM dollars for the things you mentioned, for housing navigation, for enhanced case management, for street medicine teams. They're using it to really jumpstart projects around recuperative care. So there's a lot of activity going on in the non-strictly housing world, but I think people are still trying to figure it out in the housing development world. Turner Center is doing some interesting work to think about translation, because some of this is also people don't speak the same language. So houses have certain incentives and approaches they are taking to serve their clients, and the healthcare sector has a different approach sometimes. So I think some of this is also as people really see the examples, and we need to be doing a better job of really highlighting examples where people are able to successfully match healthcare dollars, housing dollars, and homelessness dollars, because sometimes people just don't know it's possible. So it's a mixed bag, I'll just be honest, and some jurisdictions are using it in different ways, and others have just not used it as much.
Thanks. That's fair. So some incredible innovation and more opportunities to learn and figure things out. And stay tuned. I think in April there will be some case studies published by the Turner Center exactly around what you're talking about. Cheryl, you work with a number of frontline providers, local governments, and managed care plans across California. Could you give us a real-life example of how CalAIM's housing supports have helped communities better serve their clients?
Yes, I'll share a few briefly. We are seeing that CalAIM Housing Supports are helping communities better serve their clients because homeless service providers are now paying attention to who has active Medi-Cal, and when someone is not enrolled, helping them to enroll. So that's a big difference, and that's new for them. We are seeing a number of CalAIM housing support providers also braiding in funding with other CalAIM programs like enhanced care management or dehabilitation or other grant programs, and so they are reporting that that is enabling them to make their services more robust, to pay more attention to health-related needs, and to serve more people. And then we're also seeing some continuums of care and other homeless service systems now integrating CalAIM referrals into their processes. So they are automatically, as they encounter people experiencing homelessness, they're not only enrolling them and assessing them to be a part of the coordinated entry system, but they're also then making referrals to CalAIM housing supports and enhanced care management. So that is better serving people because it's enabling that person to be served with multiple programs in one visit rather than having to navigate all these systems independently. And then lastly, I'll say that we are hearing from Medi-Cal members who have received housing support services. Particularly what is powerful for them is that the service providers are coming to meet them where they are. So that's in encampments, in shelters, on the street, or in their home. And I do hope that we'll be able to hear from more Medi-Cal members in the coming year.
Thank you. I think everyone's sort of hearing the promise of the policy around CalAIM, and then, you know, there's the implementation, and implementation is challenging. It's change management, and I really appreciate, Cheryl, you being here. You've done a lot of implementation work with local governments, right, providers, and managed care plans, as we said. Given all the work that you've done, can you speak to what you've seen going well around implementation and also what's been challenging?
Sure. I'll start with the pain points so that I can end with what's going well, to end on the positive. I think we heard it mentioned by a few panelists. The biggest pain point by far is the lack of affordable housing for people with extremely low incomes, and that impacts the effectiveness of the services. So there are tens of thousands of people who are now receiving housing navigation transition services, which is incredible, but providers have nowhere to navigate them to. And so that impacts the member, the providers, and the plans. And then there's the natural growing pains when rolling out any new Medi-Cal program, that especially one as big and bold as CalAIM. But I'll say that for homeless and housing service providers, they are having to enter into a completely new and different and very complex system of care. Moving from a grant-funded system where you're receiving funding up front, you serve as many people as you possibly can, you submit the data and reports, to a healthcare reimbursement model where you are being reimbursed for services and receiving payment 30 to 90 days after those services are provided. So for these providers, it requires a lot more back office staff that they didn't have because the operations administratively, financially are just that much more complex. And many don't have the cash reserves to upfront these costs, and that is impacting housing deposits because plans aren't able to enroll as many providers into their network because these providers just don't have the cash reserves to upfront the cost for housing deposits. I can speak to what's going well, though.
Great.
I'll say the grant programs that Susan mentioned and that Dakshika mentioned, every success story I've heard from CalAIM Housing Supports providers has been that they received at least one grant from HIP or IPP or PathCited, and that has been a catalyst for them to be able to hire those back office staff, have startup funding, and keep these services going. So that has been tremendous to their success. And then I have also heard from providers that this is helping them professionalize their services, and they love these services, and they've said they're not going back. This is their new way of doing business. So it's really changing the field in a positive way. Last thing I'll say, we also are hearing from affordable housing owners and supportive housing owners And they are saying that more people are staying housed and they are seeing fewer evictions as long as people are receiving those tenancy-sustaining services.
Thank you so much. I am cognizant of the time, so I think what we're going to do is ask Dr. Kuchel to sort of give us the, 2 to 4 big takeaways from what we've heard on the panel today, and then we'll open it up to questions, both in the room and on Zoom, and spend the rest of the time doing that. Before that, I just want to remind everyone that there is an evaluation in your packets for those in the room, and for those on Zoom, when you're done, there will be an evaluation that pops up online, and I encourage you all to fill these out. But Dr. Kuchel.
Great. I mean, I think we heard a lot of excitement and potential from both the 1915B waiver and the 1115 waiver for things like the housing trio, which is this novel way that we can now use health dollars to really support key things to both help people get into housing and stay in housing, as well as these community support services that I think are key. And then we heard a lot about integration. So we heard about integration at the state level and the role of the ICH to really bring together state agencies to look at pain points, try to get through them, try to increase communication between those agencies. And we learned about the really critical role of data, which can seem geeky, but actually I think can really lead us to know if what we're doing is working or not. Particularly, we heard about the merger of all of the HMIS, or local COC data, up to the statewide level through the system that's now called HDIS, and really excitingly, the merger of that system now with healthcare data. So in some ways, this is like the writ large, the macro level of merging these systems in an important way. And then we heard about, of course, the action plan that is recently released and will be talked about soon, which will be using metrics to really look at that. And then finally, I think we heard on the ground of the ways that these funds, when used right, were able to be braided together to really increase the robustness and power of the services. Some really exciting things like that now COC providers are really invested in Medicaid and helping to meet people where they're at. So when they're getting them into coordinated entry, they are simultaneously making sure that they are eligibilized for Medi-Cal and getting the right services. And while we heard some pain points, the pain point that we just don't have enough housing, and that these are really flexing new muscles. And I think particularly we heard for a lot of the CBOs who've had to move from a grant funding model to this, in a way, fee-for-service reimbursement model. But I think we can end on a high note that there are things that are being used to decrease the pain of those pain points, and a lot of excitement for these grant-funded programs which will actually build the infrastructure. I was really excited to hear about the hubs, which really for the MCOs to help bridge the distance between the MCOs and Medicaid managed care plans and the community services, so that each one doesn't have to figure out how to bill on their own, but that administrative burden can be centralized. So lots, I think, of a recognition of the hard parts, but also a lot of excitement for the potential for these mergers.
Thank you so much for that expert on-the-spot analysis. Appreciate it. Okay, so I think maybe while folks in the room get thinking about what questions you have, I'll start to address some of the questions that are coming in on Zoom. Susan, I'm going to ask you this question. Can we use CalAIM to build housing?
So first, I'll just state that, Medicaid is first a health program, and generally speaking, per federal statute, healthcare dollars can't be used for housing. So we have received the waiver under the 1115. The 2 community supports that I mentioned actually pay for room and board are under the 1115, and it's really temporary, right? It's for the short-term post-hospitalization housing and recuperative care, and now we have the allowances for the transitional rent. So generally, Medicaid does not pay for housing, And we have very specific waivers to pay for room and board under our 1115. And those are the three areas that I just mentioned: recuperative care, short-term post-hospitalization housing, and now newly transitional rent.
Thank you. Okay. Oh, you have a question there? Okay. Question in the room.
Thank you so much for the presentation. It was really informative. My name is Adro. I work with United Way California Capital Region. We are a community supports provider, providing the trio here in the Sacramento region. I wanted to ask the question, really, as you alluded to some of the challenges on the federal level, we really are looking at supporting and advocating for these programs, seeing the transformation that it makes in individual members' lives. And I really had a question around the data of the cost savings, because CalAIM, a lot of it is supporting individuals who have high complex needs and are high utilizers of services, and diverting them to housing supports can reduce some of the costs. And what data do we have in terms of lifting up that message of cost savings? Because I do think that that would resonate with this administration, and to really preserve this 915 and 1115 waiver.
Great, thank you for that question. Very good question. That is actually under our special terms and conditions, which is contract under the waiver. We are actually required to do an evaluation of exactly what you just said, looking at the effectiveness of community supports, and as I mentioned, they are provided under an in lieu of services framework, which says that you provide these services and you will be saving healthcare dollars in other settings. We have engaged UCLA RAND to actually do that evaluation. It is an independent study. Will be coming out. They're collecting data on everything from total costs of care to also looking at specifics on emergency department use for individuals that are, for example, taking advantage of the community support services. So those are some components that we are looking at, and that evaluation will be, the interim evaluation will be out in 2026, but that's something that we are in fact looking at. From a monitoring perspective, we're looking at specific information like just utilization trends. So are people using it? And then from again, from an interim evaluation perspective, we're looking at those cost savings questions as well.
Great. While we wait for the microphone to move, I'll just ask another Zoom question. And any of you can really address this. What are the lessons learned from the Housing and Homelessness Incentive Plan? And Cheryl, you alluded to the impact it's made. I don't know if you want to take this.
I think we could frame it as a lesson learned, but we need startup funding for these services to be successful when you're bringing in a network of providers, of community-based organizations into a completely new sector. And so I'd say we've learned that, and we've seen how successful it is when you have that funding available.
And I'll just add, with the Housing and Homelessness Incentive Payment Programs, we had very specific measures that plans had to achieve in order to earn those incentive dollars. So some specific measures, for example, has there been data use agreements that have been executed? So we've seen, and those are exactly the types of measures that we wanted to measure through the HHIP. Ultimately, the purpose of the HHIP, one of the main goals was actually to bring together the two sectors that normally don't even talk to each other, right? So having the COCs work with the managed care plans. We do know that, for example, some of the managed care plans have actively engaged with the COCs. They're working together to even be on some of the boards of the COC. So there's very much a lot of integration happening at the local level, because we said, no, we're gonna measure this, and that you have to show that you've actually achieved these measures to earn those dollars.
Thank you. Okay.
Hi, my name is Chris Erdman, and I want to address both the pain and the pleasure that Cheryl, you were talking about. So I'm with Yellow Cares, which is a CBO, a regional provider of end-of-life care for people on hospice palliative care. We've now added ECM through a wonderful grant through the state, $3.5 million, to build all that infrastructure out. So what we're facing, though, is that we have a menu of CS services, which include recuperative care, housing navigation, day hab, post-term, short-term post, but we haven't accessed the full trio, and that's because of the pain. So we're going to do housing navigation and day hab, which is not a trio, but we're not doing housing deposits and transitional rent. Why? Because of the cash outlay. So, CBOs like ours can't afford the seed fund to be able to outlay the cash and then wait on the MCPs to pay us back. One of the MCPs, and we're building contracts with all of them, they're marvelous in contracting, but one of them, who shall not be named, owes us $300,000 right now on housing and room and board for housing patients. What can we do to reform the system so that we don't have the pass-through of state funds that go to the MCPs, we provide the benefit, but we don't get paid back? Why can't we go straight, or why can't we get paid directly rather than the cash going to the MCP, they're earning interest on it while we're waiting for reimbursement?
So I'll just address first, you had a lot there, a lot to unpack, which we should talk later. Just generally speaking, the way Medicaid is structured in California, we do provide our services through the managed care plans. That is the structure that is essentially, we get our dollars from, it's a state and federal partnership, and we have contracts with our managed care plans. And in those contracts, we have very specific requirements on what needs to be, benefits that have to be required, network, sufficiency provisions, et cetera. Also, timely payment of claims is a very specific requirement. So I'll just say that's how we provide services through our managed care plans in the state. In terms of the just overall pain point, as you mentioned, like I said, there has been some issues that we have heard from the plans in terms of timely payments for the deposits and transitional rent. The cash outlay is a real concern, and not every CBO will be set up to do that. One of the things that we are looking at, and Dakshika, I think you might have mentioned this, but the flex pools are one potential solution, because housing deposits, it's a security deposit, right? Transitional rent, 6 months. So what happens after that? There really needs to be a full housing support plan and funding mechanism for that individual, really after that 6 months, which Medicaid itself can't solve, but there are other funding streams, and there needs to be a mechanism to braid all that funding. And flex pool options are, we do have a paper out that's a technical assistance resource that we can share, but essentially that is an option to consider, because the flex pool allows for funding to be basically brought in at a local level, and then there's a lead entity that would essentially serve as that administrator, financial administrator, really helping the organizations that participate in the flex pool braid that funding, and then also connect with the landlords, because of course landlords want to get paid upfront, on time. They also need to sign leases, right? So they need that predictability. So the flex pools are one area that we're really looking into and encouraging.
We have a question from Zoom that maybe Cheryl and Dakshika can address, from a housing provider who says, I have housing units and support from city and county. How do I begin to partner with healthcare organizations or managed care plans?
So managed care plans keep their provider network registries available on their websites. So you can if you can Google which managed care plans are operating in the counties that you're serving, you can then go to their websites to see who are the contracted agencies providing housing tenancy sustaining services and housing deposits. That will enable you to then reach out to those provider agencies more quickly than sort of just asking service providers, are they contracted, although that's one other way to do it. I will say that for tenancy sustaining services, there is a challenge that supportive housing providers are facing because services from a funding perspective have to be guaranteed for 15 to 20 years, but from a healthcare sort of authorization of services perspective, providers are having to justify that service every 6 months for that service to be extended. And so this is a really new thing for supportive housing providers. And as I said, we are seeing evictions decreasing, but that's as long as someone has the tenancy sustaining service. And in terms of healthcare service, tenancy sustaining services really is preventive care. You're preventing someone from falling into homelessness, you're preventing them from experiencing health crises associated with homelessness, so it can be challenging to articulate how long does someone need a preventive service.
Thank you so much. I think we'll take 1 or 2 more questions in the room. Okay.
Hi, good afternoon. Thank you so much for this excellent briefing. I had 2 quick questions. One is for Cheryl, if you have any recommendations for next steps to scale up how many people are getting the housing trio of services and to connect these services better to housing. And then I also had a question for Susan and Dakshika about the sharing of data, which I think is extremely exciting. And I'm just wondering if there are any plans for being able to identify people who are experiencing homelessness for managed care plans.
So in terms of next steps for scaling up these services, I'd say there are 2 things. One, we know that there are still providers, particularly those that are in rural areas or serving historically marginalized communities, and some continuums of care that still will need additional support and flexibility from managed care plans in order to be able to contract. I think the hub model is something that's promising. But then also we're hearing from providers what happens next, what happens in 2026. There is a bill, AB 804, that is looking to make the housing trio of services into a Medi-Cal benefit so that we can build upon what's already been so successful, and then also to make sure that it is available for Californians experiencing homelessness with complex needs for the long term. So those are 2 things I would recommend.
Thank you, Sharon. The data exchange just happened, so that is definitely one of the things, Sharon, looking at not only folks on CalAIM who are experiencing homelessness, but also folks on the CDSS programs, trying to see like folks on CalWorks, folks on the other kinds of mainstream system programs. There might be a connection with public health programs as well. The data has been sent from CalICH to CalHHS, and my understanding is, and I'm not a person who knows the technicalities here, hopefully by the summer there will be some data that we can start to analyze. So there's a group at CalHHS, there's an entity called CDII that does all the data integration at CalHHS. So once they have done that data matching, that will be an opportunity to really do a lot of analysis. So I'm looking forward to seeing that too, Sharon, but definitely people experiencing homelessness, but also looking at people at risk and thinking about how do we prevent them becoming homeless.
Thank you so much. Unfortunately, our time is up. I could sit here and talk about this for hours, but I just want you all to know we are going to put out a blog summarizing what we talked about today and answering any of the questions that weren't addressed, both from the Zoom chat and in the room. So those of you in the room, if you want to write down your questions and hand them to me, we'll make sure that they're addressed. And I just, can we give our panelists and Dr. Kushel a hand?